Moving on to hypoglycemia. Hypoglycemia is low blood sugar, and it can cause the following symptoms: sweating, hunger, nausea and vomiting, irritability, confusion, right up to a hypoglycemic coma, loss of consciousness and convulsions if untreated. Usually these patients seem like they're drunk, if anything. You walk in, you look at them, and they're like slurring their words. They can't hold a conversation. They think they're doing something they're totally not doing. So treatment of hyperglycemia includes administration of something sweet like orange juice, candy, honey, or syrup that has immediate sugar available for fast absorption. After initial treatment, you would provide them with something that has a longer release of sugar, such as a protein, peanut butter, cheese, a glass of milk. If they're in the hospital, they're most likely going to get dextrose solution, IV dextrose, and glucagon, which is going to help the liver release stored glucose. Oral and injectable non-insulin anti-diabetic agents. Type 2 diabetes results from insulin resistance combined with relative insulin deficiency, so a lot of times these people might be on oral medications before they move to insulin. Symptoms of type 2 diabetes may include excessive weight gain after age 40, excessive thirst, excessive urination, excessive weakness, poor circulation, and slow healing, as well as visual problems. And we kind of covered that earlier. Those are all part of those macrovascular complications. So sulfonylureas. The oral hypoglycemic drugs known as sulfonylureas consist of first-generation agents such as chlorpropamide or tolbutamide, and second-generation agents more commonly used such as glipizide and glyburide. The second generations have higher strength and higher potency, shorter duration of action, better tolerance, and fewer drug interactions. Sulfonylureas increase insulin production from the pancreas and improve insulin activity and reception on the periphery. So in other words, that's fancy words for basically it makes insulin work better. Usually people will start out responding really well to these medications, and it'll slowly wane over a year or two, so they might need a higher dose or a new medication. I'm going to have you guys cover anything that's listed as a side effect, precaution, or contraindication, as well as an interaction. Otherwise, we'll have 3 videos. Alpha-glucosidase inhibitors. The main one we see here is acarbose, which delays digestion of complex carbohydrates, makes it slower. So it also delays subsequent absorption of glucose, resulting in a smaller rise in glucose after a meal. It can be used as monotherapy, which means by itself, or in combination with insulin, metformin, or sulfonylurea. You guys cover the rest of that section. Again, you don't have to memorize these, but it is good to pick out side effects with these medications. For example, some of them just make sense. For acarbose, high rate of GI effects, gas, abdominal distension, and that's because we're keeping food around for longer in the GI tract. Biguanides, there's only one, metformin, and it works by decreasing hepatic glucose production and enhancing insulin uptake in muscle tissue. This is usually the first-line therapy that most diabetics will start on, given with a meal and given twice a day. Incretin therapies. GIP and GLP-1 have been identified, and those are 2 hormones that are released by cells in the GI tract in response to food. Agents that mimic the actions of these hormones may be beneficial therapeutic options. Usually there's a couple, I believe, oral and a couple that are injectable. We're going to cover first exenatide, which is a GLP receptor agonist. It's given underneath the skin, sub-Q, twice a day, and it mimics the action of the incretin GLP-1. So therefore, it will, when food is eaten, it'll mimic that same hormone. It decreases glucagon secretion, delays gastric emptying time, and decreases food intake, meaning you feel fuller sooner, so you're not going to eat as much. So exenatide or Byetta is the most common one. Bydureon is a long-acting form of that. And it's a pretty popular medication these days. It actually helps patients lose weight because they feel fuller sooner. Common side effects include nausea, vomiting, diarrhea, etc. It's not used in patients that have severe renal disease. Sitagliptin, saxagliptin, and linagliptin, given orally once daily, are the oral version of these medications. Common side effects, again, abdominal pain, diarrhea, nausea and vomiting, respiratory tract infection, and again, history Pancreatitis warrants a little bit of caution before we go using these medications. Meglitinides. Starlix and Prandin, or nataglinide and repaglinide, stimulate the beta cells of the pancreas to produce insulin, again used as monotherapy or in combination. Rapid onset, short duration of action, taken before each meal. Thiazolidinodiones, that's a long word. We call them TZDs. We don't want to say that word. It's a very long word. Actos and Avandia are the most common ones. These are falling out of favor though because it came out a while ago that they put the patient at risk for heart failure. They increase the likelihood that the patient will have heart failure. They decrease insulin resistance and improve insulin sensitivity in the muscle, liver, and adipose tissue. Again, monotherapy or concomitant with other agents. So we talked about congestive heart failure. They're not to be used in patients with advanced heart failure, that's stage 3 or stage 4, class 3 or class 4. There's also a black box warning for the potential increase in the risk of myocardial ischemia. In other words, basically decreased blood flow to the heart. And side effects: weight gain, fluid retention, and edema, upper respiratory infection, sinusitis, headache, etc. These are some pretty serious drugs. They can work well for someone, but they should be used with caution. So that covers diabetes. It's kind of a whirlwind tour of diabetes. And really what we want to get you to get out of this is that patients can be on multiple medications, what the classes of medications are, and why we might use insulin. So if you guys have any questions on any of that, please give me an email. Otherwise, have a great week.